Thank you, Dr. Sethi, for that beautiful introduction. I'm very, very moved. And thank you to Professor Kalangos and to Dr. Sethi for inviting me, and to all the people who have put the seminar together. Thank you very, very much for inviting me. I'm going to focus my talk mainly on children, but a lot of what I say you can transfer across to adults. So before I begin, I'd like to introduce you to this gorgeous little man. His name is not actually Rahul, but I've changed his name. And we first met him when we went to Hyderabad. So Dr. McAlpine and I, and also Dr. Sakrapani, we were invited to go and see a hospice in Hyderabad. And this little fellow, before going to the hospice, they asked if we would like to go to and see a home visit. So we went to see little Rahul here, and he's 3.5 years old. He was born with CHD, has TOPVC, non-obstructive, and he's just a regular little 3.5-year-old in terms of loving to play and smile. And next door lives his grandfather, his grandmother, and his 2 aunties. So you would think that he has plenty of support, but he doesn't. You see, Rahul's father is an alcoholic. He's into domestic violence. His aunties mentally torture Rahul's mother, emotionally and mentally. And his grandparents have decided that even though the surgeon said there's a fairly low risk in surgery, he actually quoted 2 to 5% in his notes, that the child was not to have surgery. His mother is voiceless. Watching him and interact, that's the social worker there with the little dinosaur in his hand, and watching them interact, and the mother being able to speak to the social worker, speak to the nurse, to actually have support, reminded me that healing is not about cure. It's about connection. It's about hope. It's about heart to heart. There are many Rahuls in this world. A lot of children are in such dire circumstances. In fact, we know that there are 21 million children alone that need palliative care, and we know that every year 1.35 million children are born with CHD, and it's estimated between 21 to 25% of those children need palliative care. So palliative care, what is it? We know it's helping to the child or the adult to lead a dignified life. It's to support them through that journey. We know in humanitarian in situations, we still can do palliative care. It's just we have to adapt to many changes. There's many changes, but we can do it. And I really want to stress that. And it's actually our professional duty as health professionals to provide palliative care. So let's get everybody on the same playing field here, because there's quite a lot of misconception about palliative care. It used to be for cancer patients, but now it's for anybody that has a life-limiting condition or in a life-threatening condition. It used to be for end of life only, but now it's for the trajectory of illness with anyone who has a life-limiting and life-threatening condition. So the benefits of early palliative care is symptom control, there's support for the family, there's advanced care planning that can be done, there's improved quality of life, which of course is what palliative care is about, and there's reduced hospitalization, and there's increased bereavement support. And I'd like to share a little story there. I've recently come back from a a conference in the Philippines on palliative care for children. And one lady told us the story of, in a war-torn area, this woman was had given birth to a child who had congenital heart disease, and she had another child. He was 12 years old. The father had walked out of the marriage because the second child was not perfect, so he had left the mother. And this particular day, the mother went to the shop. Oh, sorry, the son was asked to go to the shop to buy something for the mother. When he was at the shop, a bomb went off. He was killed instantly. So this mother left with a child with CHD, and it had Down syndrome. Fortunately for this mother, the doctor, after the child had been born, referred her to a palliative care service that was operating in that area. And so they were able to scoop up this mother and support her and care for her and get her through the very traumatic time that she had to experience. So early intervention or early recommendation to join palliative care is essential. And children in crisis still need comfort. We often focus on curing our kids, but we still have a responsibility to help those who we're not able to fix with interventions or surgery. So there are challenges in humanitarian settings. There's limited infrastructure, financially, there's not a lot of people on the ground doing this. There's cultural sensitivities, there's stigma, language barriers, medicine availability, emotional toll that it takes on the staff. But none of these things should be excuses or prevent us from providing palliative care. And we can do it in very simple ways, and I'm going to get to that right now. So I'm going to give you 5 strategies to help you with how we can consider and apply palliative care. The first one is to consider integrating palliative care at stage of diagnosis, that it should be woven into every mission, right from the outset, as a collective philosophy of the team. That way, everybody is on the same page for those kids that we can't help with surgeries or interventions. We are open to helping them through palliative care. The second strategy, which is very, very important, is to connect. Now, often in clinical practice, we forget the power of communication. And many of you out there are the ones who have to, who have to break the news to the parents that their child, that you're not able to do surgery, that there are no medical interventions possible, or that you are on a waiting list for surgery, and we know often that children will die waiting on a waiting list. So what I really want to impart is breaking the news is essential, but how we do it, you need to be honest and upfront with the parents, but you've got to connect to their heart. The minute you tell a parent that their child has a severe condition that is not treated, the parents are not, that's it, shut down, not listening. You've just told them the worst possible news. So going with technical stuff and all the rest of it is not going to help them. Right at that point, you need to connect heart to heart. You need to soften it. And you can do that very easily by saying simple things like, we are here with you on this journey to support you, your family, your child. I know this is not the news that you have expected, but you are not alone. We are here to help you. It only takes 40 seconds, And after 40 seconds, you've connected heart to heart. You've got them. You've got the parent's attention then. And in fact, even if you're using an interpreter, and the interpreter is what you can do is just look at them and connect to them, because it's so important for those parents to feel right then, there and then, that you are supporting them. They don't want to know everything you know. They want to know that you care about them. The other thing I'd like to say is to keep it very simple. I have an example. Our sister-in-law had just dropped down, collapsed 2 hours after we'd had a family gathering. My brother rang me. She was rushed to hospital, and she was diagnosed with a major ruptured aortic aneurysm. So we sat there, and the doctor came in, and for 5 minutes sat in front of us and went through all the scans and the results in technical detail. Do you think my brother at that point wanted to know all that detail? He just wanted to know, Mr. Martino, your wife has had a terrible brain bleed. We actually can't do anything right now, but we've set up the back of the emergency department, which they had. There's an area for you to go there. Our staff will support you. Be with your wife right now. That's what we needed to hear, not technical jargon. So be very careful of how you communicate. It's a very important part of our professional way that we interact with people. So there's a beautiful saying from Maya Angelou, who said, they won't remember everything that you've said to them, but they will remember how you made them feel. And that's our first step, to connect to them, to introduce palliative care in a gentle way, in a positive light. And trust is a valuable currency in our connecting to our patients. Remember, poor communication causes suffering. It's not our job to cause more suffering. Some conversation tips. Sometimes you don't know what to say. So sometimes things like, we're here to focus on you and your child and your family, is a gentle way again of approaching of how we can help the family. Support, respect, empathy, dignity. Very important in how we deal with our patients and palliative care. The next is the context. Where are you going? What country are you working in? Before a mission, look at what's already in place. Are there some palliative care services in place? Who can you liaise with? Who in your team can find out what's on the ground there? Are there social workers, counsellors, people associated with palliative care, so that when you come to that country and you diagnose kids that need palliative care, you know what's available? And let's think outside the square. Let's actually perhaps even include on our mission teams, perhaps there's a retired palliative care specialist or a social worker or a counsellor that would love to come on a mission and be part of our team, where they can help local people with palliative care, setting it up, guiding them on what to do. So we can be part of that. Recognize that in context of the country, that siblings can be suffering in silence too. So you've got to look at the whole family situation, the cultural influences, the environment, but also the family dynamics, because it's the mothers that actually bear the emotional and social weight of what is happening. Rahul's mother is a perfect example. I can give you another example of my time in Fiji when we had a mother, a little 4-year-old boy who had a massive VSD that needed repairing. Father brought him in. The little boy needed to be in the isolation ward because he had a runny nose. And after 24 hours, the father, as we say in Australia, he spat the dummy. He had had enough. He wanted to get out of the hospital, take his son with him. The mother, who is 7 months pregnant, came and said, "No, I will stay with him." She really wanted him to have that surgery because she knew it would give him a new life. He had the surgery, he did super well. I went to the market one day to buy some fruit and vegetables, and there she was with her stall. And I looked at her and I said, "Baby." Her baby was stillborn at 8 months. Her husband blames her because she came to the hospital and stayed with the child that operated on. These are the sort of situations that happen. And I'm sure many of you have many of those types of stories. We need to understand in context the environment we're working with and how much the mothers and grandmothers, often the grandmothers have to take care of the kids too, because the mothers have to go to work or whatever. Just support your team because it's very stressful work. And a lot of people get quite emotional about all the work we do. There's lots of education, free education on palliative care that you can access now and that your teams can access. So I just wanted to put that little point in there because we're working in very stressful environments, in different environments. We go there with good intentions, but often not everything works out the way we want it to. Low cost, high impact actions, effective communication, emotional reassurance, family education, all these things are palliative care in action, little things we can do. Telemedicine is huge. That's a way we can reach out to them. And we can also use WhatsApp groups. When I was in Fiji, I set up something very simple. I said to the nurses when we got palliative care patients, get an exercise book, write 4 or 5 columns, put the kid's name down, and get not 1, 2, but 3 contacts, phone contacts, because they always, change different telco companies, etc. So get 3 or 4 contacts, family contacts, so we can follow up. All you need to do is every now and then give them a phone call, let them know they've got support, let them know they are being thought about. Am I going the wrong way? Am I? Contest, yes. Which way? It's up the top bottom. Top button. The next one is champion. Be a champion of the cause. Advocate for palliative care. Be the voice of the children. Build capacity in your cohort, your team. Network. So many of you have people that you know who are counsellors or social workers or bereavement support that can be part of your team. Network, advocate for palliative care. We need to look after these kids and form partnerships, collaborate. There's many wonderful NGOs and church groups, faith groups that are very, very willing to help and assist with palliative care. Another story from the conference, there was a girl in South Africa, a nurse, and her passion was to be able to go out to the area and serve some kids with palliative care. And within 12 months, a wonderful church group came. They were able to give her a van. It was all kitted out, and she was able to go over, and she'd mapped out what sort of territory, because she knew all these kids needed palliative care, but there was no local resources. And so now she's able to do what she wanted to do. Good intentions and her wish came true. So we all have an individual responsibility. We can network and help and put people aware, make them aware of these children that we're not able to help medically or surgically, but we can help with palliative care. Plant the seeds, become farmers. I want you all to become farmers and start planting the seeds about palliative care. Show each mission, model compassion, model empathy. Show that palliative care is a very important part of our management for kids with CHD. Be an advocate and plant those seeds. And the final one is to cultivate. And I love this quote because it's so important that the expectation that we can be immersed in suffering and loss and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. It's so true. You know, we spend a lot of our time in humanitarian work giving, 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 but we have to feed ourselves some self-care. And I'm talking about things that feed our soul or our center of peace, peace within our heart. We have to look after ourselves. And if you don't, I can tell you, you will get ill. I see it in my practice as my work. People who are burnt out, they give, 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 but there's nothing to feed and nurture the deeper part of ourselves. And simple things like nature. Nature restores us, nature heals us. Meditations or mindfulness practices, or if you have a particular religion that has practices that give you comfort, that feed and nourish your soul. Music, which is another wonderful tool to help us relax and be calm. And also care for your team. You know, a lot of the time the work is very, very stressful. In the hospital that I worked at in Fiji, there was a prayer room which was non-denominational. It was a beautiful room. And I called that the most important room in the entire hospital because it was where we could go together, support each other, care about each other in times of trauma, when things didn't go right. So it's very important that we have a compassionate understanding with each other with all the work that we do. So in summary, palliative care begins with you because you are often the ones breaking the news. It starts at diagnosis. It's multidisciplinary. It can be delivered anywhere. It works even with limited resources. It improves quality of life, it's holistic, and it can be provided alongside treatments. And that's the thing. They can still have treatments and surgeries and interventions, but we can still provide that support, that dignity, that connection, educating the family, educating the health centres, because it's the rural centres that are really the most important part of palliative care in rural settings, because they're the ones we contact and to keep contact to look after those families. So a call to action, I want each one of you to think about these five things that I've talked about. Consider integrating. Can you do that? How can you connect and communicate better with your patients? In what context and what setting are you going to? And what can you do in that setting to ensure these kids are being looked after? Become a champion. Oh, the end dropped off. Become a champion for the cause. And cultivate some compassion and self-care for yourself. This is the beautiful hospital in Fiji. that I worked at for 18 months, and that's the driveway, and it's a beautiful, the heart. You can't miss it. It's enormous, it's huge. And every day I was there, I'd walk past this, and it was a wonderful reminder to me. It was a wonderful reminder that our job is to help little hearts heal, but it's also to transform our own hearts in the work that we do. And sometimes our job we can't always cure, but we can touch the hearts in our care. And that's what palliative care and humanitarian missions are about. So thank you for this opportunity to share the heart of humanitarian palliative care. Thank you.
Able to implement and think about and really foster in our practice and when we take care of patients. I would just like to ask you one question. Within India, what is the current level of palliative care that is offered in terms of training for our young doctors?
Great. Thank you for that question. That's a really great question. It's really great because in India, palliative care is starting to evolve. Probably in the last 10, 12 years, there has been an awakening, an awareness of palliative care. There are some very good institutes within uh, India, in Bangalore, up in Hyderabad, where they're taking hold of the palliative care. There's a wonderful Indian Association of Palliative Care. So it's really starting to bloom and grow in India. And a lot of the states are taking it up and introducing palliative care into their services. So thank you, because it was something that I learned at the conference too, that it's happening, that India is really picking this up. Thank you. Any more questions?
And just a short comment. Thank you for sharing such a wonderful presentation. Um, yes, it does start with diagnosis, and a lot of times we find that it is such a shock to the family and the caregivers of the child when they get a diagnosis. And so that connection from that diagnosis truly begins to help them with that journey. And just coming from a pharmacist perspective, I think also helps with pain management as well. If we connect better and bring their anxiety levels down, we have noticed in surgical missions that the pain requirements or analgesic requirements, it does dramatically go down because they're comfortable and feel safe with us.
Very important point. Thank you. That's why communication is key. And as I keep saying, you know, it's a very important part of our work. And if we don't communicate well, it causes more suffering.
Yes, a great presentation, Helen. Thank you very much.
Thank you.
What I'm a little concerned about is the global and general awareness,
Yes.
socioeconomic, whatever, in relation to the word palliative. Because if I was to ask 20 people that I know in Perth, they'd all think it was in relation to cancer.
Yes, correct.
So I'm a little
Yep.
concerned as to how you propose to initiate some drastic change in this measure to allow people to understand it's also for children that have serious complications or injuries or operations or surgeries,
Yes.
basically.
Yes, another really great question. Thank you for asking. So there is a big movement now, when I was again at this conference that I've just attended, to really bring awareness. And in fact, in India, recently there's the Two Hearts Foundation, and they're from the US, and they came and did a big sort of advocacy and help people understand what palliative care is about. And this is why I really wanted to mention that in this talk, because so many people don't realize it is the trajectory of life-limiting conditions. And so at that conference, we were looking at how can we really spread the word and let people know. So it is country by country having to spread that word, and we certainly still need to do that in Australia. We have incredible palliative care. We're a blessed country. But as you say, most people think it's for end of life, but it's not. So there's a lot more that needs to be done. I don't have the exact answer, but there's a lot of us that are aware of it, and a lot of organisations are and are endeavouring to make people aware. Thank you.
Thanks, Helen.
Thank you.
I will say, you know, at our center for the very high risk patients, they're introduced to palliative care right away.
Wonderful.
But that's taken a long time to get there. So just, you know, with that last question, I'm wondering if they do change the name going forward.
Thank you. That's a great. I forgot to mention it. Some countries have a real problem with the term palliative care. So we're looking at other names such as supportive care programs or comfort care programs. A country like Thailand just doesn't like the name palliative care. It has such bad connotations. So that's something you can do as a practitioner too, is if there's a cultural influence around it, you can turn the terminology as a supportive care program. And we're looking at possibly, you know, that's another one to look at to see if we should change it. Thank you. That was a great question too. Thank you for all those questions. Thank you.
It's really important topic. And I think one that we're going to continue to talk about as time goes with these. So once again, thank you so much, Helen.
Well, thank you. Thank you for including me, and thank you for this topic. I really appreciate it because it's bringing that awareness. So thank you.